our first speaker, back to Dr. Barrie Tan. Now, in case you do not know, I spent one day trying to learn how to pronounce this. This Dr. Tan is the current president of the ASEAN Otorhinolaryngological ENT Head and Neck Federation. Correct, huh? There you go. So this man is here and was the president of the Society of Otolaryngology, ENT, Head and Neck Surgery, Singapore from 2017 to 2019. So this man is the GOAT. All right, so at this moment in time, please join me as we welcome Dr. Barrie Tan. Come on.
Thank you, James. Ladies and gentlemen, thank you for having me today. My name is Dr. Barrie Tan, and as James has very kindly introduced me already, just a little bit about myself as a background. I started private practice in 2019. I'm currently practicing in Gleneagles Hospital as a ear, nose, and throat specialist. Prior to my starting private practice in 2019, from 2013 to 2019, I was the head of department in Singapore General Hospital, the ENT department. And from 2013 to 2018, I was also the concurrent head of the ENT department as well in Sengkang General Hospital. With regards to some of my regional work, I have been the past president of the ASEAN ENT Head and Neck Federation and also the past president of the Singapore Society of ENT Surgeons. So I bring with me some experience with regards to managing ENT conditions. Today we'll be focusing particularly on an area which brings a lot of patients into my clinic, the topic of snoring and obstructive sleep apnea. Snoring as a marker for possible obstruction when you're sleeping. And oftentimes, it's not just a warning sign with regards to your social health and your marriage, but actually it has significant implications in terms of your health if you actually do have obstructive sleep apnea and it's untreated. So it's my pleasure to share with you a few things, a few thoughts with regards to snoring, good sleeping health, as well as treatments available for the treatment of obstructive sleep apnea. Now, this is a picture that we all envisage ourselves when we are fantasizing about just having glorious sleep. It's a restful sleep, we are comfortable on our pillows, we are deep in our sleep, and we've got a deep sense of rest. What constitutes a good night's sleep? I think many of us have identified this for ourselves. It's a sleep that's sufficiently long, that's uninterrupted, that comes with a lot of rest. We wake up feeling very energized, and it's natural, it's relaxing. We don't have to take sedatives, and we don't have much trouble falling into sleep, the problem of insomnia. So these are qualities of a good night's sleep which everyone envisages as well as everyone aspires to have. Unfortunately, the truth is oftentimes we don't have good sleep. Oftentimes when the alarm clock rings, we shudder that the alarm clock has woken us up because we don't feel that we've had a good night's sleep and we want to go back to sleep. There are many qualities of a bad sleep, and some of us have identified with these over the years. Sleep can be too short, it can be very broken and interrupted, where you awaken spontaneously at night. You can find it very difficult to fall asleep, and it's long to slumber. You might actually have nightmares during the time when you sleep. And when you wake up, you often have this sense of fatigue, as though you never actually got to sleep in the first place. Snoring, when it comes around to all the symptoms with regards to bad sleep, is one of the most typical symptoms which is evident in today's society. And it brings many patients into my clinic. And oftentimes, snoring as a marker of deeper underlying disease is a very strong marker and a strong indicator. Oftentimes, it's the spouse who hears the snoring and suffers the consequences of the snoring. But the true indicator of the underlying disease and the true victim of the snoring, if it is associated with obstructive sleep apnea, would be yourself. Let's talk a little bit about snoring first. It's a fluttering sound that arises from the upper airway during sleep, and usually it occurs at several levels of the upper airway, primarily at the soft palate level or deeper, where it is close to the bottom of the throat, near the tongue or the walls of the throat. Basically, you need a mobile piece of tissue to vibrate and cause a little bit of that flutter sound. Primarily, it affects the spouse, as I mentioned, or the bed partner or the family. There are different grades of snoring. Sometimes there are certain classifications or terms which we use which can sound quite funny. There's a term called heroic snoring, where basically it's not that you are a hero, but basically it's so loud you can hear it through a closed door. But essentially, when you snore, you interfere with the peace, the literal peace of the whole household. It leads to direct poor sleep for your partner, who oftentimes has to put earplugs. It may lead to repeated poor sleep for your partner, which then leads to domestic tensions. And all this while, you may think that you are blissfully sleeping, but your partner, unfortunately, doesn't have the same quality of sleep because he or she has to deal with your snoring. But most importantly today, we're talking about it as a marker for underlying airway obstruction. And I would say it is actually a very strong marker for underlying airway obstruction. This is a pictorial that basically represents how air usually reaches our lungs through the upper airway. We have several orifices or openings in our head and neck by which we can breathe. We are designed naturally to actually breathe through our nostrils, and that is the most comfortable way that we can breathe, because as we breathe through the nostrils, air picks up humidity from the tissues of the nose. It reaches eventually down to the throat and then into your windpipe in a humidified fashion, and it's comfortable. However, you can alternatively also breathe through your mouth. You can open your mouth to breathe, but the saliva glands in our oral cavity and in our oropharynx are not designed to humidify the air. And oftentimes, as you breathe through the mouth, you might actually develop dryness of the throat or a sense of irritation or discomfort in the throat, and it's not generally as comfortable as breathing through the nose. Snoring in itself, which I mentioned just now, causes significant problems also with the bed partners, and oftentimes leads to a lot of tension between bed partners. There's a term that's actually called sleep divorce, where the most irritating time of the day between a couple is during a sleep. And the couples therefore decide that in order to maintain the literal peace in the household, that the couple will split and sleep separately when they are actually sleeping. And that's known as sleep divorce. We hope to be able to avoid sleep divorce for you and your spouse, and we're here to offer you some nuggets which hopefully you can bring back and try to deal with the underlying issues that you may be facing. Let's focus now on the health issue. Because snoring in itself doesn't cause health issues to your own body. As I mentioned, it causes problems to your bed partners and the family. But the underlying health issue that will be of concern to you, if you do have any underlying obstruction, is a condition called obstructive sleep apnea. It's called OSA in short. And basically, there's an obstruction to your upper airway airflow during your sleep. The duration can vary, but untreated obstructions repeated over the years will lead to significant health implications to your body. You can obstruct at several places in your upper airway, and we'll discuss the upper airway anatomy later. But basically, either you get partial obstruction, which leads to insufficient oxygenation, or you get complete obstruction, which not only leads to insufficient oxygenation, but a lot of uncomfortable sensations for the body, physiological stress, and therefore compensation mechanisms to be able to unblock yourself. Now, in obstructive sleep apnea, we talked primarily about snoring as a marker, but there are other potential clues to the fact that you may have obstructive sleep apnea. You could actually, apart from snoring, be witness to stop breathing, and oftentimes the spouse is a little bit afraid that you may actually be dead in your sleep because it suddenly becomes all quiet and there is no snoring. But oftentimes, after a period of witness apnea or a break in that snoring, there's an associated choke or a gasp where you might actually physically try to unblock your snoring or unblock your obstructed passage and take a deeper breath. Oftentimes, these choking and gasping episodes are witnessed by the spouse and the family, but not by yourself. Sometimes you do wake up and you wonder why you've suddenly woken up. If you sleep alone and you sometimes wake up in the middle of the night huffing and puffing or trying to catch a breath, you should think maybe you did have an obstructive event and therefore you are trying to get a better breath. Oftentimes, obstructive sleep apnea leads to restless sleep, frequent tossing in bed, awakenings because the brain doesn't get enough oxygen. It lightens your sleep. It gets you into a stage where you're easier to awaken. And also then it leads to broken sleep. Nocturia, which is a frequency in going to the toilet in the middle of the night, is another symptom of obstructive sleep apnea. The daytime symptoms are quite well known. We wake up feeling unrefreshed. There's also excessive daytime sleepiness. This is particularly dangerous for patients and people who actually are in very physically demanding jobs. They can be working in very risky jobs. Some can be long-distance truck drivers. Some can be actually operating heavy machinery. And you not only become a hazard to yourself, but you become a hazard to other people around you. You may wake up feeling very groggy in the head. You may have a brain fog sensation. You may have headaches. You may wake up with a sense of a dry throat, or you may have depression. You may not know why. You just feel so depressed all the time with a low mood, or that your brain doesn't seem to be as active as it used to be. Sometimes you may have also, because of poor sleep and poor rest, therefore the less inclination to perform sexually as well. The dangers of obstructive sleep apnea on your body are multivariate, but untreated, it can lead to many cardiovascular problems. It can lead to hypertension, abnormal heart rhythms because your heart beats very fast and in abnormal rhythm sometimes. Your heart muscles may develop very thick muscles, but they may not pump properly and may lead to heart failure. There's atherosclerosis that's closely related to untreated obstructive sleep apnea as well. And other diseases, stroke, diabetes, mellitus, glaucoma, they are at a higher incidence in patients with untreated OSA. And of course, we mentioned a little about workplace accidents or driving accidents when you are excessively tired. Now, the upper airway comprises the nasal passage as well as the soft palate, and then eventually down to the oropharynx, and then eventually to your windpipe. You can actually get obstruction in any of these levels in your upper airway. This is just to show you some of the typical features that we see and typical anatomy that we see in the nose passage. So these 4 pictures shows you the different portions of the front of the nose and eventually reaching to the back of the nose. This is a healthy nose and an open passage. You get a clear passage around the inferior turbinates of the nose, and it reaches the back of the nose, which is not obstructed. In the oropharynx or in the throat, you sometimes will see obstruction from either the tongue or large tonsils or a palate that is either too soft and too redundant and tends to be too floppy. This is a picture from a scope again, where we are looking from the nose down into the throat, and we can see the structures of the voice box as well as the back of the tongue, and also that transition between the nose and the throat, which is at the soft palate. Some common physical signs which usually we see in patients with obstructive sleep apnea would include being overweight, where deposition of the deep fat leads to increased floppiness of the upper airway. There could be nasal obstruction from deviated septums. There could be a large inferior turbinates which block the entrance to the nasal passage. There could be excessive collapsibility and loose tissues in the soft palate, which makes it prone to snore and then to close. There could be large tonsils, a large tongue, as well as excessive tonsil tissues on the back of the tongue. These are the ways that we usually investigate and confirm whether you have obstructive sleep apnea. There is a study called a sleep study conventionally, but the medical term is a polysomnogram. But basically, we are monitoring various parts of your breathing at night, and we synchronize that with your body position, as well as your heart rate, as well as your brain wave monitoring during the night, so as to determine whether you do obstruct in the middle of the night as you're trying to breathe and sleep at the same time. The different stages of sleep are captured by the EEG monitor. The heart rhythm is captured by the ECG single lead. There are leg movement monitors, and there are breathing monitors in the nasal passage, as well as your chest movements. And also we look at the blood oxygen levels through the pulse oximeter as well. These are some representative graphs which are captured from the data that is elucidated from a sleep study. And basically, when we get these sleep study results coming back, we want to tell the patients whether they do have obstructions, and there are essentially 2 types of obstructions that we are able to measure. The first is called apnea, where there's complete obstruction, no airflow going through the nose, must last for at least 10 seconds, and we synchronize that at the time when your chest is actually trying to rise, trying to get the air into the lungs, but there's no airflow detected in the nasal prongs. Hypopnea is a partial obstruction where the amount of airflow going through the nasal passage has reduced. There is still airflow, but it's reduced. Must last for more than 10 seconds, but at the same time, simultaneously, we're detecting a drop in terms of the oxygen in your blood. So your pulse oximetry has dropped by more than 4% saturations when you get this partial obstructions called hypopnea. And these are important for us to determine in terms of how frequent they are happening during the night. Because there is this important number called the apnea-hypopnea index, how frequently the apnea and hypopnea is occurring on an hourly basis. If it's more than 5 times an hour, then you actually have obstructive sleep apnea. And as the number increases, then your OSA severity increases from mild to moderate to severe. And there's another term which is oftentimes used interchangeably with the AHI. It's called the Respiratory Disturbance Index. But basically, it talks about frequent awakenings due to obstruction as well. For those who cannot tolerate a full sleep study, there is an easier method in which we measure for breathing as well as obstruction in the night. It's called a watch PAT. The PAT stands for Peripheral Arterial Tonometry. And basically, it measures your heart rate, oximetry, and also different qualities of your pulse as you breathe at night. And it has been shown repeatedly on repeated studies that it is up to 89% accurate when correlated with a full level 2 sleep study called a polysomnogram. And so therefore, it's adequate for the use for diagnosis and for us to dispense treatment. So say you've been diagnosed with OSA, what can you do? There are different types of treatments. Oftentimes, if you are overweight, we'll encourage you to lose that weight through exercise, a balanced diet, which we'll be hearing much about later on today. But the mainstay in terms of the treatment for obstructive sleep apnea would be the use of a machine called a continuous positive airway pressure machine. This is basically a pump which collects air from the room environment and pumps it out at a gentle air pressure, and then when connected to the face, it basically seals the upper airway and keeps the upper airway open with a gentle air pressure. Now, oftentimes patients may not be so happy with the use of a CPAP machine, and they ask for alternatives. And see, these are some of the alternatives which are possible. A mandibular advancement device is designed by the dentist, and basically it can be used during night sleep like a mouth guard, and it basically helps to keep the tongue forwards by keeping the mandible or the jaw forwards. So you wear this to sleep, and it helps to keep the jaw forwards. So this is a non-invasive way of treating obstructive sleep apnea as well. There are various types of surgeries which can be targeted at the different sites of obstruction. You could address deviations in the nasal septum. You could reduce the inferior turbinates to create more space in the nasal cavity. You could remove the tonsils to create more space in the oropharynx. You could do surgery on the soft palate to make it wider, stiffer, prevent it from being so easily collapsible. You could actually reduce much of the tissue in the tongue base to create more space just above the voice box. You could perform radiofrequency on the soft palate to scar the soft palate to make it a bit stiffer. And there are more advanced skeletal surgeries such as maxillomandibular advancement surgeries, hyoid suspension surgeries, which help to keep the airway open furthermore. And the last step is a tracheostomy. Now, we'll just talk a little bit about some of these surgeries. Radiofrequency is basically energy that's delivered and it creates a burn. And this series of pictures below shows inferior turbinates which are large and swollen before radiofrequency reduction. And the top series of pictures shows radiofrequency reduction and healing after that, where the front part of that turbinates has been reduced. We can do more extensive work if we want to. We can actually straighten the nose septum, make it straight. We can actually resect that turbinate entirely to create a real open tunnel from the front of the nose all the way to the back of the nose. And this is called an inferior turbinectomy as well. And the straightening of the center wall is called a septoplasty procedure, where we straighten it and make the airflow equal between both nostrils. We can do surgeries on the soft palate as well. And in these soft palate surgeries, while it's quite extensive and it may be potentially painful, but the pain lasts for only a short period of time. And with the eventual scarring that happens, we are able to create a soft palate and an upper airway that is wider and more stable than what you had at the beginning. So in this surgery, we will be able to trim the uvula, which is like the little dangly tissue, which you see right at the back of the soft palate. And then we are able to remove the tonsils, do a few stitches, hitch it up, and then basically widen your soft palate. This is the end result of a patient who has undergone surgery called a uvulo-palatopharyngoplasty with tonsillectomy. You see deliberate scars being created, and basically the scars keep the upper airway and the soft palate wider, lifted up, and it's stiffer, so the soft palate doesn't vibrate so easily, and so it doesn't collapse. And the last surgery which we can do is a skeletal surgery, and this is a representation of one of the skeletal surgeries which we can do. And this is quite a major surgery. It usually is done together with the dental surgeons. But basically, we advance your mandible, which is your jaw, as well as your midface, which is known as the maxilla, forwards. And with that, we create more space at the back of your tongue and also the back of your airway so as to keep it open. So we've come to the end of all the various types of treatments that we have available for the treatment of obstructive sleep apnea that's currently available. There are some new treatment strategies that may come on board, but we'll share that as they develop more results in the future. With that, it's been my great pleasure to be part of your webinar series, and I hope this session has been useful to you. These are my contact details. Do feel free to reach out to me or my clinic staff, and we'll be happy to help you with further inquiries that may be helpful. Thank you.
Oh, thank you, Dr. Barrie. I enjoyed that so much. Thank you very much, sir. Thank you. Thank you.